I'm Dr. Salil Kandwala, and I'm the medical director at Advanced Urogynecology of Michigan. Today, we shall talk about the combination of prolapse and bladder pain syndrome. We shall discuss the anatomy, also the causes, the symptoms, and the signs, what typically the workup is, and what are the management principles. So this is the typical female pelvic floor, as you can see from this, looking from the top down. This is the front, this is the back, and these are the muscles that basically fill up the bottom of this pelvic cage, and that's why it's called the pelvic floor muscles. On top of that are the ligaments, and these ligaments are very important to keep the structures properly in place so that they do not weaken. At the same time, they are well protected by the muscles. So the normal outlay of the pelvic viscera in a woman is as follows. So you're looking at a woman from the side. This is the top, this is the bottom, this is the front, this is the back. So this is where the pubic bone is right here. This is the bladder right behind that. The urethra is the tube that brings the urine outside. Behind that is the vagina. On top of that is the uterus, and behind that is the rectum and then the buttocks. So that's the typical way the organs are displayed in a woman, where they're properly in structure and not falling down and properly anchored. So how does prolapse occur? So let me explain you through a simple animation of a boat and its moorings. So you can see that the boat is essentially the uterus or the vagina. The moorings are the ligaments, and the water, which is keeping the boat afloat, are the strong pelvic floor muscles. So when the muscles are strong, the organs are held nicely and the ligaments don't have to do a whole lot. However, if the water starts decreasing, that means the muscle is getting weaker, then there is more strain on the ligaments, which starts increasing in stress and strain as the pelvic muscles start weakening, and they're pulling and pulling and pulling. Ultimately, they break and there is prolapse. So it's truly the interplay of the muscles and the ligaments which are important to keep the organs in proper position. So if the muscles weaken, like in this case, see how the muscle has fallen down, and the ligament, the white structure which is broken, that'll predispose to prolapse. So what are the typical causes? Why does this happen? And there are many causes. The number one cause is gravity. We are standing and doing everything standing up. But then you have insults such as childbirth, as the baby's coming through and there are tears and stretches and nerve impairments. Then strenuous activities such as ongoing coughing, lifting, constipation, which is not just once, but this is a persistent happening. Weight, which is a constant pressure on the pelvic floor. Menopausal changes because of lack of estrogen, and the connective tissue weakness that could be inherited as weak tissue. So what are the types of prolapse? So when we look at the different organs, in the front, you got the bladder, the urethra, the vagina, uterus, and the rectum. So the cystocele, or the front wall prolapse, is when this area right here, the front cavity, the front wall of the vagina is falling down. So here's again the bladder, the urethra. As you can see, the bladder is coming down, and it's come down even more, and that is called a cystocele. And this is a classic large cystocele that is coming outside the vaginal opening. The middle part is where the uterus is coming down. As you can see, it's coming down to the opening, and now the uterus has fallen outside the opening, and this is a classic uterine prolapse. Then you have the back wall. So I showed you the front wall, the top wall, and now this is the back wall of the vagina. You see how it's bulging forward as the rectum is bulging into the back wall, and or the small bowel is herniating in the upper back wall, and the small bowel loops are pushing out, usually seen after a hysterectomy. And this is a classic back wall prolapse. So what are the typical symptoms? This is very, very important, especially in a patient who has bladder pain syndrome and prolapse. It is very important to understand that the main symptom of a prolapse is the presence of a vaginal bulge. It is not pain, it is not pressure or discomfort. It is the fact that something is falling down. For a bulge to cause discomfort, I mean, it has to be huge. The symptoms are not due to prolapse are pelvic or lower abdominal pain, pelvic or lower abdominal pressure, and pain during intercourse. So remember, a patient who has bladder pain syndrome may have these symptoms also, but that is not because of the prolapse. I mean, if you think about this condition here during intercourse, guess what happens? The woman is lying down. So what happens to the uterus and the prolapse? It actually goes inside. When it goes inside during intercourse, what happens? The penis is further pushing the organs back to where they belong. So if anything, the bulge should be improved in a patient who has just a prolapse rather than cause any worsening discomfort or pain. Now, in a patient who has bladder prolapse, because it's falling down, the urine may get trapped in here, and that can give a sensation of difficulty emptying, incomplete emptying. That means I just went to the bathroom, I've got to go again. Sometimes urgency, especially at night, because what happens at night is when the bladder goes back inside, then she has the tendency to go more because now this urine wants to come out. It can cause retention, and because it's not emptying, it can lead to bladder infections, and that can also cause urgency leakage and something called occult or hidden stress incontinence. So as you can see, the urethra, the tube, this is the urethra. As the bladder is falling down, guess what happens? The urethra is bent. And because it's bent, it's almost impossible for a patient to be leaking. That's the reason why she's not emptying. So this is classically why they get, incomplete bladder emptying sensation. Now, when you look at the bowel sensations, the back wall, because the rectum is bulging forward, there's a lot of problems with constipation. Sometimes the patient has to push on the vagina or the perineum to reduce this. Because of the constipation, there's a lot of gas production, and she has a lot of gas leakage that happens, or sometimes it can also cause stool leakage. Bladder pain syndrome, on the other hand, has main denominator is pain and discomfort. Remember, pain and discomfort. So pelvic pain, pressure, or discomfort typically associated with the bladder, with one other bladder symptom such as frequency in the daytime or at night in the absence of a bladder infection or other obvious pathology. So the kidneys, which are in the upper back, they produce the urine by filtering the blood. The urine is then transported by these two tubes into the bladder, and the bladder stores it, and when it's right time, it lets go. Now, that is controlled by the nervous system. What happens is that the A and the C fibers are the two nerves that usually carry the sensations. The A fibers carry sensation of touch and pressure. So while I was talking, on this video, you were watching me and listening to me, but you could ignore the chair that you're sitting on. And that's because you could feel it, but it doesn't bother you. However, if the chair becomes like a hot plate, then you will jump off and say, what happened? And that's the C fiber. It carries the sensation of pain and temperature. In this, the A fiber carries a fullness. Your bladder is filling up. I can wait, no issues. C fiber, the bladder fills up. It causes intense urgency and frequency, and you have to go to the bathroom or there will be discomfort. Normally in the bladder, the A fibers are active, so all is good. But if the C fibers become active for some reason, then you will have increased urgency, discomfort, and a sensation of pressure and also cramping. So this is what happens, unfortunately. In patients with bladder pain syndrome, you have a nerve imbalance in favor of the C fibers. One other theory quoted is that you see this layer right here, it's called the gag layer. The gag layer is almost like an insulation layer between the urine solutes and the nerves on the outside. And if that gag layer, as you can see here, is broken, if it's broken, it's not complete, then the urine solutes can go through the lining of the urothelium and irritate the nerves, and this irritation can cause an inflammatory response and activation of the C fibers. So again, remember, the symptoms may not be due to prolapse. Just to reiterate, urgency, frequency, sensation of incomplete bladder emptying, and constipation. Now, you remember, I told you that yes, they could be sometimes, but we have to be very careful before we absolutely label it, especially if a patient has the other findings associated with bladder pain syndrome. So the first examination is done for prolapse in lying down position. Then I may have you bend your legs up on your belly to see the extent of the prolapse. And finally, this is a very old 16th century picture of a French physician examining a woman for prolapse in the standing position. So if I cannot see the prolapse, then I'll have you stand up and strain down, putting a one leg up on the examination table, and then look for the evidence of prolapse. The patient herself, you could be doing the same thing. After you go to the bathroom, you can push down and see what can you feel, and you may be able to do a self-examination. In women who have prolapse, they do not have any vulvar pain. But if there is bladder pain syndrome, then a simple Q-tip touch to the vaginal opening. This is the opening of the vagina right here. This is the woman with the legs up in the lithotomy position. This is the buttocks. This is the anus, and this is the vaginal opening. And you can see just slightly touching it, lightly with the Q-tip causes intense pain. Similarly, just palpating the bladder, I put my fingers in the bladder and just slightly moving them forward and touching the bladder can cause severe pain in a patient with bladder pain syndrome. When the patient starts getting pain, then the muscles of the pelvic floor, the ones I showed you before, they go in a spasm. And when they go in a spasm, then the spasm itself causes discomfort and pain. So what do? The typical workup for a bladder function assessment, so a woman who has a cystocele, which is a large bladder prolapse, we check for making sure the post-void residuals, so a little bladder scan that you already had done, and that is to make sure that the bladder is emptying well. We do the voiding diaries. Now this is important for both the urgency, frequency, and to see what the bladder compliance is in a woman with bladder pain syndrome and also for prolapse patients. Then the 3-day diary also is important. So the 24-hour diary is mainly to see how often does she go to the bathroom, when she went to the bathroom, what was the amount of urine that was produced, and was there any leakage, and if there was leakage, why did it happen, and what was going on at that time. And on the right two columns are what she had in terms of fluids and what type of fluids. 3 days an enumeration of how many times she goes, whether there is any urgency leakage or any coughing leakage, and how many times she goes at night, and leakage episodes at night, and number of pads used. So the key thing is this, voiding diaries. Is prolapse the cause of the bladder dysfunction, or is this due to bladder pain syndrome? This is very important to understand. So that's why this will tell us about the bladder compliance and accommodation. That means if the compliance is decreased, then it's a problem with bladder pain syndrome. Does she have any urine leakage? What's the daytime and the nighttime difference in urine production is also important, and the fluid intake. So why is this important? Because in a patient who has a large bladder prolapse, when the prolapse goes inside, then she starts emptying her bladder more at night than what she's capable of doing in the daytime. The urodynamic testing is another test, which is where we fill the bladder up and do some pressure recording to see if the patient has urinary leakage, what are her bladder sensations of fullness and first sensation, and therefore assess the compliance. Compliance means how much can she store in her bladder as we fill her bladder up. Does she have urine leakage? Is there any difficulty emptying the bladder? If patients who have retention, then we would know why does she have retention? Is the bladder contracting or not? And we assess for something called hidden urine leakage. Again, the key thing is the prolapse the cause of the bladder dysfunction, or is this due to something else? This is very important to make sure and confirm. So what is this hidden leakage? Remember we talked about as the bladder falls out, the urethra gets kinked. So now this is where you push the bladder back in place. We hold it in place with 2 sponge sticks, and then we have her cough, and boom, she starts having leakage. Why? Because the urethra is no longer bent. The other test that we may do is look inside the bladder, especially when there's urgency, dysuria, blood in the urine, or history of frequent bladder infections. We make sure that the bladder itself looks fine. So again, as I mentioned, it's for retention if she's not emptying, frequent bladder infections, especially blood, and history of smoking and bladder cancer. Now, from the bowel function standpoint, we do what is called stool diaries, and that helps us assess the type of stools, whether she has constipation, what's the frequency of bowel movements in a week, and also to see whether she has any stool leakage. Then we do a couple of bowel tests called anorectal manometry and anal ultrasound and defecating studies. So this is where an anal ultrasound is done. So this is the probe that's put inside the anal cavity. You can see this black structure, right? The black halo is the inside muscle, and the white halo, which is all complete around it, that is the outside muscle. So this is a good, complete, and a proper anal sphincter muscle. But see here, the black halo is relatively okay, which is the inside muscle, but the outside muscle is essentially absent here. You see this arrow from here, it goes all the way till here, but it's not up here. And that is where there's a muscle tear, and that could result in bowel leakage. So when we talk about the management, it is important to see what the patient's complaints are, and also very, very important to make sure that the symptoms are because of prolapse or is because of bladder pain syndrome. And that's why it's important to understand the value of these tests, and they're very important to come to the correct management. The problem is this: if the discomfort is blamed on the prolapse and we come up with an incorrect diagnosis, it'll lead to an incorrect treatment. And guess what? If the nerves are already agitated, by operating in that area, they will be further agitated and the symptoms will be worse than what she initially started out with. So it's clearly important to understand what are the patient's symptoms, what is the main bother, is it because of prolapse or is it because of the bladder pain syndrome, and appropriately manage it. Both can be managed at the same time also. So that's why I was mentioning it's differentiate between this and recommend a test to help with it. So please complete the diaries that we've given you, undergo the appropriate tests, and you should read the information and also watch the videos that I've given you for the management of these two conditions. So if the main problem is prolapse, then a prolapse is very common. 1 in 10 women have it. Large prolapses are not good to keep. Just don't wait because they can cause complications. Treatments have dramatically improved now, dramatically. Even if we did a surgery, it's done entirely from the vagina. There is no belly incision, there is no laparoscopic incision, and there is minimal pain or discomfort, and most patients go home by the next morning. If the main problem is bladder pain syndrome, this is, remember I said, it's a very misdiagnosed condition, so we have to be very careful. We do not want to say that's prolapse and treat it because it could be misdiagnosed as prolapse. Treatment is very successful, and you have to help me help you. And we'll discuss the management in a subsequent video about the bladder pain syndrome management. Most patients have significant improvement and they do not even need any surgical intervention. So forget about all this, hanging a woman upside down like the medieval times to correct the prolapse or to tie her up to help with her abdominal discomfort and pain. It's all archaic. We have come far, far from that. And there is so much that can be done to help with both these conditions. So there is absolutely no need to live with either one. And they can be properly managed as long as you and I work together.